All this is Dr. Mobeen Sayed from drbeen.com. Welcome to one more show. So this is a chit chat. How is everyone doing? How was your weekend? Arun is here with a question. Arun, I love it, man. You get us started with the questions. Can two or more viral strains interchange their genome and become more contagious? So if it goes on, virus can escape vaccine-induced immunity one day. So let me answer your first part of the question. So I'm going to share my screen. Give me 1 second. So the first part, that can viruses interchange their strains? So that would probably not happen. So let's say this is one virus and its genome. Let's say this is Delta. And then we have one more virus and its own genome. And let's say this is Delta plus. Actually, you know what? Delta plus should have been called Delta minus from an effectivity point of view. But it is called plus because it has one more mutation on the gene. Anyways, now saying that can they interchange, that is kind of not simple. However, question is that is it possible that they continue to become more contagious? Yes. So remember, we are seeing the example of this. We had original variant, let's say Wuhan, then that changed to Delta. So there is a set of changes that are on top of it. Then Delta has another set of changes that are on top of it. Imagine if Delta plus changes were also more, making it more contagious. So now it is more contagious, if at all. Then imagine there are more changes on top of this. Then it could become more contagious. And if you keep going, then yes. Now the question is, what you're seeing with the SARS-CoV-2, for example, SARS-CoV-2 is not going to get, I think it will not get enough chance to develop into SARS-CoV-3 during this pandemic. I think we are almost ahead of it. We will get ahead of it in time, and I don't think it would become SARS-CoV-3. But in theory, as your question is saying, if these changes continue to happen, then eventually either it will become more lethal or it could become more contagious and less lethal, or you can call it more humanized. If it becomes more humanized, which it seems to be doing, then it is fine. It's going to become less lethal to us and it would just start living with us. It's learning to live. So if it has to become more contagious, then it will have to be a SARS-CoV-3. For it to be more contagious, it will have to have enough changes to escape previous immunity and to bring in new damaging factors that would start killing us or making us sick altogether all over again. So far, not happening. That's a good question. So Celtic says, thank you, Dr. Been. Very concerning news from Dr. Corey. He tweeted, Math Plus not working, patients crashing in ICU, early treatment is critical. Thoughts? I think that, so I have to read that and have to talk with him, but it can make sense that, so let me explain why it makes sense. So we know, let's compare both viruses, original variant and this variant. So let's say this is original variant, Wuhan. We know that when it infects someone, it took 5 days. That was mean time, correct? Mean means about 50% of the population would show symptoms by this time. It used to be anywhere from 2-3 days to, let's say, 7 days or 10 days. Mean was 5 days. Within 5 days, the symptoms will appear. What does that mean? That means in 5 days, the virus will build up enough in number, in load, and cause enough tissue damage that we would start getting the disease or the symptoms. Now, in some people, the virus would then continue harming and cause even more tissue damage and more intense response, which will then result in cytokine storm. Correct? And this would take some time. And what would happen is that normally, while we are moving, a patient is moving towards the cytokine storm, the immune system has started to build up, and it has started to beat up the virus. So virus's load will be contained or maybe even reduced. And hopefully then, if you can catch the cytokine storm in time, you could pull the person out. Now, with the new variant, the, let's say, Delta, what's happening is it is causing damage faster. Why? Because it is more contagious. So if it causes damage faster, and let's say within 2 days it appears with the symptoms, that means damage is fast. That also means that by 5 or 7 days it has done much more damage to the tissues. That means the response from our body could be much more intense as well. So what is the best way? That means either you ask the patient not to wait at home or just come in right away, or give them something prophylactically. So it is the speed with which it is traveling or infecting the cells which makes it less controllable. So from a mechanism point of view, his tweet makes sense. I haven't seen the tweet. Anthony says, thank you, Dr. Been. Can vaccine increase monocyte infection with S1 and add to pool of NCM and long COVID? Also, are breakthrough infections evidence of non-neutralizing antibodies? Thank you for all you do. You're very welcome. Let's explore both pieces one by one. Good questions today, right from the beginning. So first one, vaccine increase the monocyte infection. So let's say we have injected a vaccine, whichever it is. All vaccines eventually are making spike protein. So let's say there is spike protein made. So spike protein pieces are shredded. Those pieces are then presented on the surface. There are some spike protein, if the cell is broken down, they are out. Those spike protein might get digested by monocyte or macrophages. Now, these spike proteins that have been taken up by monocytes can cause the issue that we're talking about. There is also a possibility that a cell that is exhibiting pieces of spike protein, that cell will be killed and eaten up by the monocytes, which once again, when they eat up the cell, they would eat up everything inside the cell as well, which can bring the spike protein into the monocyte. And once that happens, then this monocyte is going to get mad. So that is one possibility. The question that is really in my head, which I do not have an answer for, is why is the quantity so much to cause enough number of monocytes to end up causing the long haul outcome? My thinking, and I may be wrong, is that there is some way that these cells further give the spike protein to other cells. How do they do it? I do not know, because vaccine is not unlimited like the original infection. So from the infection, it is understandable that more and more cells will become infected and they will be eaten up, and they would leave their S1s possibly in monocyte in some people. But with the vaccine, there is a very tiny amount. If that amount is sufficient to cause monocyte issues, then sure, that is what is possible. But we are seeing that this is happening. Now, the second part is the breakthrough infections evidence of non-neutralizing antibodies. No, it's not that. I have explained it before as well. So breakthrough is happening at the moment because, and maybe there is non-neutralizing antibodies in some folks, which I'm not aware of. So it's not that it may not be happening. It may be happening. But normally what is happening is as the virus arrives in a person whose immune cells are actually just sitting in the bone marrow and they're sleeping or they are inactive. And as the virus enters the person's body and starts increasing, this immune system is going to take a few days, 10 hours, 24 hours, 48 hours, various times for various people. During that time, virus has open season on our cells. And the result is it's going to keep killing them. Then our immune system is going to wake up and start responding to the virus and contain it. Hopefully, that containment would bring us out. So we may have just some symptoms, maybe even hospitalization, depending upon the person's own status as well. But hopefully, not death. But you've seen that there are some vaccinated who get infected and die as well. Proportion is very small, but that is also possible. Now, is this an example of non-neutralizing antibodies? No, this is an example of immune system still waking up while the virus has done damage. Then, second part of it, so that's the symptom part. Second is the intensity part. We know that the intensity part is the cytokine storm. So that means in some individuals, cytokine storms are still happening. Does that mean that the immune system did not control it correctly? Possible. Does that mean that immune system actually became mad like original infection? It can do that too? Yes. So what happened exactly here is still not known. Could this be that a person, let's say, who is too weak and they got the infection and the infection caused enough damage? Let's say somebody already has a very low oxygen level because of their damage to the lungs for other reasons, smoking or some other problems. There are many illnesses. Top that off with the infection, and now even when the oxygen level drops a little more, they cannot sustain it. Or imagine somebody's cardiovascular system was not strong enough before. They had, let's say, heart attack, and then they went into cardiac failure, and their cardiac output is already low. And then top that off with a milder infection, which another healthy person might be able to sustain, and this person is too fragile to sustain that. So I think there is a combination of all of that that might include some folks in which immune system is just not able to respond. They may be immunosuppressed, their immune system may have responded incorrectly or may respond abnormally high with the cytokine storm. So good question. M. Gregory says, bottom line, if the mainstream media claims something, assume the. So mainstream media at the moment, and I think we're seeing this for about 1.5 years now, they keep beating these things into submission, the deltas and delta pluses. They torture that information so much that they make it true for us. And we become nervous enough and we become anxious enough and we start going to their sites and start reading them. And that is how they get their views and revenue. I see one more super chat here. I'm trying to see if I can. So Dr. Sammy D says 80% of cases in India is Delta versus US at 91%, UK 96%. Delta started in India and had low vaccination rates. Doesn't Delta prevalence increasing by country in order of vax rates suggest vax selected ADE? No, I don't think so. Here is why. If it was ADE, then Delta would have been going through the people who are infected, vaccinated. If ADE was happening, we all vaccinated folks or folks who were originally infected will be in trouble. That is one. Second, I have explained this part and I'm going to do it once more. And it is important to realize the mechanism of ADE and then understand if it is just the vaccine or infection, or can that mechanism happen without them? So look, the mechanism is this. We are saying theoretical mechanism, but there are 5 mechanisms. I've done a separate discussion about those 5. I'm not going to go through all 5. I'm just going to use one. So let's say here is a cell. This cell is minding its own business. This cell is a macrophage. Macrophage mean its job is to take part in repair, take part in fight, remove debris, remove pathogens, and so on. Eat the pathogens up, break them up, present them. So it's a macrophage. Macrophage can pick up a pathogen in a couple of ways, multiple ways. One of the way is that if, let's say, there is a pathogen here, let's say this is SARS-CoV-2. Macrophage has receptors on it called toll-like receptors. And they have, macrophages have many kinds of receptors. They have PAMs, and they have DAMs, and they have TLRs, and then they have receptors for complement, and they have receptor for Fc gamma portion. They have a lots of kind of receptors. I'm just selectively using some to make my point here instead of teaching about the receptor. So let's say this is a toll-like receptor. Macrophage's job is to recognize a pathogen using its toll-like receptor, and if it finds a pathogen, then macrophage is going to eat it up, phagocytose it, break it down, and number one, present it. That is, so macrophages are in 2 states. One is a non-active state, and then the other one is active state. Within the active state, then they could be classical active or non-classical active. Non-active state is, imagine if I'm a macrophage. I am just strolling around, I'm walking around, I'm looking at things, and I'm touching them, seeing them, and if I find a pathogen, I eat it up. I am not in an active state. I'm just patrolling. So once I eat up the pathogen and I present that on my surface, then there will be some naive T cell that would come and engage there. In part of the immune activation, the immune system would amplify me. For example, interleukin 12 and interferon gamma. Interferon gamma could be released by T helper 1 pathway. When interferon gamma is released, that activates a macrophage. An active macrophage would actively start doing phagocytosis, this is Luffy sleeping next to me, would actively start picking up pathogens or broken cells or infected cells and eat them up and kill them. That is an activated state. So what is the difference in active and non-active? Non-active is a slower pace activity. Active pathogen is, macrophage is just going to pick up things very fast. Now, within the active state, it can then be classical or non-classical. But I want to go somewhere else here. Macrophages also have Fc, they have receptors called Fc gamma. What are these receptors? When an antibody is released by B cells, so let's say this is an antibody. When it is released by a B cell and it binds with a pathogen here, then macrophage can bind to this part which I made red. This is the constant part of an antibody. This side is called the variable part. Constant part of the antibody can actually bind here with the pathogen attached to it. And this binding allows the macrophage to eat up or phagocytose this whole complex, digest that, break up the whole thing, and be done with it. This is a normal process. It happens in everybody. It happens in every immune response. The idea of ADE is that when this binding occurs and when this complex is brought in, the virus, instead of getting digested, so let me make it here. So let's say this is inside of the cell, and that complex has been brought in phagocytosed into this phagocytic vacuole. This is the same macrophage just zoomed up, and that vacuole, that bound thing, the complex, has been phagocytosed. Now, ideally, this vacuole is going to be digested. The content inside are going to be digested, including the antibody. Antibody will be destroyed, plus the complex, the bound thing will be destroyed. Now, here is the idea of the ADE. The idea is that when we try to start digesting here, there are some pathogens that use that acidity to their advantage, and with the acidic environment, they activate enzymes that would break open this phagocytic vacuole or the stomach, and the virus would, or pathogen will come out in the cell, and now it would infect it. For example, Bacillus anthracis does that. When it is eaten up and it is in the vacuole, it would actually, when we acidify the vacuole to digest it, it actually uses that acidic environment to become active with its enzyme and break the vacuole and come out and infect the cell and kill it. Now, SARS-CoV-2 does not have any such enzymes to become active. But let's assume it does, right? So we're going to give a provision here to say, let's do ADE. Now, question is, will the ADE occur in vaccinated and previously infected or unvaccinated as well? So what are the needs for the ADE? We have two needs. One, there should be pathogen. Second, there should be antibody. Third, the pathogen and the antibody complexes should be in the blood. These are the provisions. Now, if you think about it, even if it is a new infection, even when we are infected newly with the virus, we are going to make antibodies. We are going to make antibody antigen complexes. These are going to settle on the macrophages. And if there is going to be a chance of ADE, may that be a new infection or vaccination or a previous infection, they all are going to result in antibody formation, which is going to result in antibody antigen complex formation, which, if ADE is possible, all three of them would do ADE. So the idea that somehow vaccinated will dispose people or predispose them towards ADE is incorrect. The basic provision is the following, or this could be with the complement as well. Just like we are talking about antibody and antigen complex attached to the Fc receptor, there is also a possibility that the pathogen and the complement proteins that attach to pathogen could then bind to complement receptors and then get ADE'd. And there are 2 or 3 mechanisms here as well, which I have discussed separately. All of these cases require body's response, production of antibodies, complexing of the antibody to antigen, and then eating up that complex. Where are the people disingenuous in here? Where are they deceiving? The deception is the following. They are saying only vaccine-generated antibodies will be non-neutralizing. That means if this is the pathogen in the future, these antibodies would bind to the spike protein inefficiently, not kill the pathogen, and now this complex is going to get attached. The deception is the following. There is no antibody that kills the pathogen. All antibodies bind with the pathogen in the same way. The concept of neutralizing antibodies versus, let's say, binding or sterilizing is the following. In the case of sterilizing antibodies, there is enough protection at the entry. For example, in the case of SARS-CoV-2, entry will be mucous membranes. That means there is enough IgA in the mucous membranes that the virus cannot break through that IgA boundary and enter the cells. We're not going to be able to produce that kind of protection with the natural infection or with the vaccine. We just cannot have enough IgAs present in our mucous membrane all the time for SARS-CoV-2. Then, if that is not possible, then all immunity, may that be natural or vaccine induced, is going to be neutralizing, which simply means the antibodies will bind. Now, what is binding only and neutralizing? The concept of leaky. Binding only is said to be binding, let's say, to other parts of the virus than the spike protein. And now they're saying, and again, this is wrong, and I'll explain it. They're saying, well, you know what? If it is not bound to the spike protein, or if it is weakly bound to the spike protein, and I'll explain what does that mean and how that is crap message. But let's go one by one. Let's say bound to the virus other than at the spike protein. Here is this. They say if this happens, this complex will then be, because the virus is not dead, this complex would then be eaten up by the macrophages and ADE can occur. The thing is this, even if you bind to virus's spike protein, virus is not dead. Virus is not dead. So that this complex can bind to a macrophage just as good as this complex could be. So then what is really the deception again? The deception is this. They are saying it is the spike protein. Imagine the antibody does not bind with it. It has become defeated. Antibodies, instead of binding to the spike protein, it is binding somewhere else, or not binding to spike protein at all, or binding weakly. That means the spike protein is now free to infect a cell. It will infect a cell. Look, this is natural. If we leave the spike protein alone, then what will the spike protein do? Attach to ACE2 and start infecting the cell. That is just like a normal natural infection. Where will the pathogen be? If the immunity has become defeated, the antibody immunity, then the pathogen would infect the cell and go in the cell. Yes, infected, and now we have a problem. If the antibodies are defeated, the virus is going to infect the cells. If antibodies are not defeated, virus is going to become bound to the antibody. Antibody is going to be picked up by phagocytosis. So the whole mechanism is deliberately made into a confusion. These folks know that they are lying, and they just hope that majority of the people do not know this. There is no mechanism. So here, if you like, I can repeat this. There is no mechanism here that would say a virus, because of the previous vaccine, will be more dangerous. And Dr. Sami, I hope it answers that. I spoke for a little bit, but basic idea is just this. Virus, this is the virus. Antibody with it. This complex can become attached to macrophages and become phagocytosed. That is a normal process. That is what we expect it to do if we had the original infection and we want the response to occur, or if we had the vaccine and we want the response to occur. If after the original infection or after the vaccine, the antibody cannot bind with the spike protein, then this virus would infect the normal cells. So that can happen with the natural infection or with the vaccine. And if this happens, we have a SARS-CoV-3. Now, will a vaccine cause this? That also is just BS. So we can do a complete talk about it. I'm trying to keep it as uh, summarized as possible as well. But all the mechanisms you explore, actually, if you look at the mechanism of ADE, after the natural infection, if ADE was happening, then after the natural infection, the chances of ADE are going to be more than after the vaccine, because vaccine is going to generate spike proteins only, so antibodies only against the spike protein. A natural infection is going to make antibodies against majority of the virus. That means that coating of the spike protein would occur against a lot of parts of the virus. That means these complexes would occur. That means phagocytes can ingest them more. And so this does not happen. It's an incorrect thing that people have been doing. So Zachariah Magallan says, question, so are the variants not real? No, variants are real. I guess that question within your question is that if variants are real, that is only because of the vaccines. That is another deception. So see, the folks who are causing these deceptions have put those seeds in people's minds. So if your subtext over here is that if variants are real, then that also means they would only originate in vaccinated people, and that also means that is only because of some ADE happening, then the whole structure thinking is incorrect. But if you're just asking generally, variants are real, just like the virus is real. There was a good question. Iron Bubble says, how can we increase the white blood cell count? So usually increasing white blood cell count is not under our control. Neither we should try to do that with any supplements that say we can do it. White blood cell counts go up and down based on the need of the immune system. Although we need to increase or have more active natural killer cells for SARS-CoV-2, for which I have done a discussion, forest bathing or being near plants and woods and trees, then relaxing, laughing, um, doing light exercises, staying less stressful would all increase the natural killer cells plus activate the natural killer cells as well. The reason is that when you are relaxed and you are less stressed, then you get less stress hormone, epinephrine and others. The epinephrine's function is to reduce the production of natural killer cells and to inactivate the natural killer cells that are already present. So we don't want to have stress hormones. And what we do is, of course, we try to de-stress ourselves. So original antigenic sin, Zunar, I talked about it. Same mechanism as I just discussed here. Original antigenic sin's idea is once again that you somehow produce weaker antibodies that cannot neutralize a pathogen, and then the pathogen goes rampant. So once again, it's a very simple thing to look at. Same mechanism as I discussed before, but let's say I get a vaccine or I get a tiny exposure to infection, which is not possible, but let's say in theory, and there is a set of immune readiness, which is not good readiness. That means when the actual infection occurs again after the previous infection or the vaccine, my immune system cannot attack the virus and take care of it. Now, if that happens, the rest of the immune system is going to start working just like a normal immune system and take care of the virus within 5, 7, 10 days. In this case, if a person's immune system has failed, then he is or she is exposed to the pathogen as it was a new pathogen, and some of them would die and someone would not. So it is not really the original antigenic sin that did it. It's just the immune system was not able to handle it. In some people, that is possible. They may have immunosuppression. They may have been on medicines that suppress their immune system, and so on. Now, the idea that somehow there can be vaccines that will not cause original antigenic sin, then the more important thing to keep in mind is that for the SARS-CoV-2, original antigenic sin is not seen. So because of that, for this kind of virus, these mechanisms, they even tried it in a lab to try to produce this, and they were not able to. Colin Hamill, you're very welcome. Colin has a question. If you're otherwise compromised, does having a positive attitude help you with no matter what you may be suffering from? Yes, generally, when you have less stress hormones, then your body's functions are better managed. Body is in a better state of energy utilization, better state of giving energy to those cells that need it. Plus, less stress hormones would allow all cells to function correctly. A stress hormone, um, um, the evolutionary theory, and again, if you don't believe in evolution, then you won't believe in it, then just know that this is body's response. The the response of the body is the following: when we are under stress, our body thinks that the best thing to do is to have us be ready for running. Everything else is secondary. That means GIT function is reduced. That means other bodies functions, immune systems functions, everything else is reduced except muscle function is augmented, brain function is augmented, everything else is said to be stopped. Because of that, now if we are not running, we are not in a jungle, there is no lion chasing after us, we're just sitting in this chair and we are stressing, then our body would be in a compromised state, our cells will be in a compromised state, especially immune system cells, and that would cause issue. So normally de-stressing would actually help. um, she HP says, can you comment regarding effectiveness of op- opaganib? I will have to read it up to understand what kind of medicine is that. Okay, just looking for the questions. So Vilina says, thanks, Moorhouse Joplin. I was hoping to get confirmation that I had virus before getting vax. Nick Gibson says, question: study of vaccine versus natural infection. Antibody screened against 2000 viable RBD spike mutants and found less average neutralization to delta spike and much more mutant spike evasion in natural infected. Thoughts? I have to look at that study because I have done other studies as well. I've shared them, which actually said quite a robust response after the natural infection. Again, I would not recommend natural infection to anyone because that can kill as well, and we do not know who will die. Okay, so let's see. Jeremysia says, should 7.8 billion people be vaccinated every year, or is science mixed with irrationality? I do not know if your question is a cynical question or just a rhetorical question, or is there actually a question? If you say, should 7.8 billion people be vaccinated? So, my answer is, I have done this many times before. People who have become infected and recovered, healthy, good recovery, they don't need vaccine, number one. Number two, there are people who can actually manage this virus or handle this virus much better. And so, if they would like to have that chance, they can do it. Then, number three, we are actually seeing that there are certain side effects that are occurring in youngsters. And so, youngsters manage the infection better. So, there could be a pros and cons discussion of them, their parents, and their doctors to discuss. So, should we vaccinate all? I don't think so. Should we vaccinate those who are at risk or who want to? Yeah, sure. So Paulette says, how is beautiful Luffy? Let me see if I can show you how Luffy is doing. He's sitting next to me. Let's see. I'm going to change my camera, and that is going to look really, really uh, uh, jarring because the other camera is a webcam. But let me show you how Luffy is doing. Do you see him? So he's actually sleeping here with me. He loves to sleep next to me. Mhm. So, Moorhouse, poor Luffy. So, what happened was, for about a month, Luffy has been really upset with the cats outside. And at night, there are raccoons that come over in our backyard. So he becomes very upset. And I think he's now in that age that he wants to have his territory. So he has started marking. So what he does is he urinates almost everywhere. Wherever there is a window or a door, he can look outside, he would urinate. So what we did was we started having him go out, and then the problem of going out is that he was not fully vaccinated, so we got him vaccinated. He has a chip now, plus um, he's now on anti-anxiety as well, because as he started going out, he started picking fight with other animals. So he would fight with them, and he would run after them and chase them. And I was afraid that he's going to get injured. So I we took him to the vet, and they gave him anti-anxieties for the time being. So he is on anti-anxiety, and because of them, he gets his normal dose is quarter dose. Even then, he becomes then sleepy after the medicine, and he just sits next to me and sleeps. Okay, so let's see. So Bot OP says, how common is post-vaccine long haul? Do I need to worry about it before getting a shot? I do not know. So there is not enough data. And I think one of the reason there is not enough data is that the authorities, administrative leaderships, they're not really counting it. Ideally, this should be counted and they should be um, discussed. I have heard of a lot of people. I have in so my wife is still grappling with the post Johnson and Johnson side effects. It's more than 4 months now, and fortunately, I think she's 90% recovered. She does her normal day-to-day things very well. But for example, yesterday she continued to have shortness of breath. And I said, why do you have shortness of breath? And she said, I don't know. So he asked her to talk with the doctor today. So she develops these random side effects that she never had. And she doesn't have to have shortness of breath. She's a healthy young woman. So then she develops joint pains every once in a while. And Johnson & Johnson says that the Johnson & Johnson vaccine can continue to make antibodies for 8 9 months. That means it continues to trigger the immune system or bother the immune system. Why? I do not know. Then I have a another number of patients who are post vaccine long haul. It was very interesting for me that there is a doctor who has been on our show as well, had been um, on Twitter saying that I have never seen a post vaccine long haul. And he thought that everybody else who's saying that there is a post vaccine long haul is just making it up. And folks like me are trying to sell snake oil by saying that people who are on post vaccine long haul should take ivermectin. And secondly, he thought that folks like me and Dr. Corey and many other are simply scaring people away from vaccines. But I look at my wife and I feel bad that she had vaccine Johnson and Johnson. So I am a pro-vaccine person. I've taken vaccines, my whole family, and if again we will make the same decision. The only thing is I'll ask my wife not to take adenovirus. I had said that last time as well, but we just did not have the right assertion in our decision. So there is a possibility of side effects. Teresa Huber says, how long does a vaccinated person infected with COVID shed the virus? So this is another very common question. So let's see. How long should we vaccinated folks shed the virus? Let's say somebody is vaccinated, fully vaccinated. Here they get infected again. The virus lands in their mouth. There is no way to tell the virus that this person is vaccinated, do not end up in their mouth. I have done this discussion last time as well. It really depends what is the person's status. For example, let's say I just became fully vaccinated yesterday. That means today I have a lot of antibodies, including in my mucous membrane. If the virus ends up in my mouth, I might even not even know, and my IgA in the mucous membrane will bind with the virus and not let it enter my cells and just take care of it, and I would not even know. It might act as a little transparent extra dose of vaccine and extra booster. But imagine if I'm fully vaccinated, then I am 3 4 months later, so that the immune system is now resting and I become infected. Now, with the Delta variant, we know that Delta variant not replicates faster, infects cells faster. That means within 2 3 days, it can actually create a higher viral load. Now, immune system can take anywhere from 10 hours to 48 hours to become active after the natural infection or after the vaccine. So this 10 to 48 hours window may allow the virus to develop enough viral load that would be shedding as well. And so if that happens, it's really 48 hours or so is when the immune system would start fighting with the virus and the virus load would start going down. Now, once again, it depends upon the person's body habitus. It would depend upon their immune system strength. It would depend how fast their immune system can now start clearing the virus out. Imagine in a normal, healthy person, it might happen within another day or so. So that means it is possible that day 2 to 3 is the time when a vaccinated person might continue to shed. It may be less, it may be more, but this is more appropriate time. If you have another person who is not vaccinated and you put them in a similar situation, then they might continue to shed for a week or 2 weeks. So this somehow this concept that vaccinated would shed and unvaccinated would not shed, that's just not right. Then there are so many ways to scare each other. This is such a sad thing. For example, somebody said to me, well, the problem is not that they both shed. The problem is that the vaccinated will not have symptoms and shed, and unvaccinated would have symptoms and shed. But that's also not correct. We know from the previous studies that a unvaccinated or a person who never had infection before or vaccine before will start shedding 2 days before they develop symptoms. That was original virus. Now the virus's count is going to be even higher because it is delta. So they would shed and they will be asymptomatic. Number one, they will be shedding while asymptomatic. That is how this virus has been transmitting. That people do not know that they are sick and they just keep shedding. So saying that they would always be symptomatically shedding so they will know and they'll sit at home, that's bullcrap. Because if that was happening, then why are we all sick or getting it transmitted? The second thought that somehow the unvaccinated will not shed as vaccinated would shed, that is also wrong. Both would shed. Vaccinated would stop shedding sooner if they are healthy people, and unvaccinated would continue to shed for a longer period of time. So that is how it will be. So Rima says, yeah, you should. It reduces your sheds from landing on others. Furry Tales. Dr. Been, in case of vector vaccines, adenovirus, what happens to infected cells in immunosuppressed patients? How the vaccine DNA is eliminated if these cells are not killed by immune system? So, good question. The DNA is eliminated in multiple ways. One is that within the DNA, there are DNases that would break it down. So normally, if a viral DNA does not become integrated into our DNA, then that would be removed. For example, we know herpesvirus or Epstein-Barr virus. It can integrate its DNA into our DNA, and then that piece of DNA can sit there forever. That is how 94% to 90% of adults have EBV in them. In the case of adenovirus, that DNA piece that it brings in is not known to integrate with the DNA. So if it is not integrated with our DNA, then that piece will be destroyed within 2-3 days by DNases. However, in case of Johnson and Johnson, they say the immunity keeps developing for 8 months. I would suspect even more. That would mean it is possible that that DNA lives longer. Now, a piece of independent DNA cannot just live longer. It must have become integrated somewhere. So it is possible, and this is my conjecture, I may be totally wrong. It is possible that the vector-based DNA just sits and becomes integrated into our DNA, and that is how it can continue to live on for a longer period of time. So now, if that is not the case, then a few days later, that DNA would be destroyed by DNases. So cells have their own DNA destruction enzymes too. Liana says, a doc told me a virus will eventually learn to outsmart ivermectin. I said, that's not how ivermectin works. Is that possible? So, good dialogue. Look, in theory, any virus or bacteria can learn to outsmart any other thing, and then our body would make something new. But here is the problem. In the case of ivermectin, the mechanism of action of ivermectin are so many that virus will have to evade them all to outsmart ivermectin. And to evade them all means a virus that is not the same virus anymore. Virus will have to cut its feet and its hands and its head to do this. For example, we know that one of the possible mechanism of ivermectin is to interfere with the viral binding, the spike proteins binding. So if that is the case, virus may evade by changing the ivermectin's binding site, just like we say it would evade by changing the antibody binding site because of vaccine or natural infection. So let's say if that happens, then the virus can still now evade the ivermectin, bind with the ACE2 and come in. Once it comes in, then the ivermectin can disrupt RDRP. If ivermectin can disrupt RDRP, now the virus has to change that enzyme as well. What will it change it to? A new RDRP that does the RDRP function but is outside of the realm of the ivermectin's binding or function. So that is second thing. And virus has to go through billions of people to start mutating in this wholesale. SARS-CoV-2 is creating variants because it has so many people available to go into them and change and come out, not the vaccines and not the infections. It's just everybody mutates it, and so there is so much mutation happening. So RDRP will have to be mutated second. Then 3-chymotrypsin like protease enzyme of the virus will also have to be mutated. Then fourth, the viral cargo binding to importin alpha and beta, importin alpha and beta, that piece will have to be mutated. So 4 mutations. Then virus will have to somehow learn to beat ivermectin, not to disrupt nuclear factor K beta. All of this, at least SARS-CoV-2 is not going to be able to do that within next 10 years. So for it to just escape ivermectin is going to be a problem. Keith Elderson says, worst system is not accepting possible plus probable. Andrew Brady says, thank you for your videos. Does Delta variant cause a shorter incubation period? Yes. Due to faster reproduction? Yes. Is it possible that a variant could develop that is far more deadly than the last one? Yes. That is how we have Delta. So could we end up with another that is even faster? Yes. That is what Delta plus, by saying plus and media continuing to harping on it, they're trying to say that it is scary, but it is actually not scary. But in theory, could we have the next version of the virus which will be even more contagious? Yes, possible. Which will have even shorter incubation period? Yes, possible. Is this a fault of vaccines or infections? No, this is just, it's a virus who found us 7 billion people to be available. It gets into our body, it changes in there, and then some of those variants escape, and some of them are viable and they can or more contagious than before. Some of them are more lethal, they would kill the person and die with him. It's a normal mechanism. It's just that for this virus, it is happening wholesale right in front of our eyes, right rapidly. We haven't seen, at least in our majority of our lifetimes, this kind of a thing before. So Be Curious says, what are your thoughts for a multivalent vaccine in regards to overall immune response? Better than booster with wild type spike protein, problems with dose response per variant spike. So you're correct. I actually love the idea of a vaccine that generates antibodies to varying parts of the virus. So I think that current vaccines, they try to be smart to attack only the spike protein, which is the most logical target, because virus cannot do much without an active free spike protein. That is, attacking the spike protein is like putting a straight jacket on the virus. But I like the idea of a vaccine that attacks multiple parts. Having said that, so far what I'm hearing is that inactivated virus vaccines are not as effective. And I remember I spoke about that once before, and Doug said it probably is. Doug, I remember that it was you, so if I'm remembering incorrect, please forgive me. I thought you had said that it could be that the virus during the process of inactivation was too much damaged, so enough antibodies and enough pattern recognition did not happen. There is something that is, and this is a very plausible mechanism. Gear Wine says, "Thank you, Rakmin. You're the single best source of timely, useful knowledge and wisdom in this situation." You're very welcome. Actually, I felt um, good for something today. If you look at my Twitter, I had tweeted a video of how the mass, I'm paraphrasing the title, how the mass mentality is disturbed. So, one of the thing in there they were talking about was that just like when a person becomes psychologically upset and they do not know that they are psychologically upset, similarly, communities can become psychologically upset and they might do things together which before or after you look at that and you say community could not do it, but communities end up in that kind of a situation where, for example, Holocaust occurred, or where uh, women were burnt, calling them witches, and now that whole community was psychologically upset and did this. And they said one of the way to solve this, when communities start slipping in that situation, one of the way to solve that is that there are people who are causing fear mongering, and they are the ones who are creating that psychological poison. The response should be number one, humor. Number two, people who can tell the community that it is okay, relax, we will come out and we'll be fine. So when I listened to that video, I felt I did not know this before. So I felt even better that we have been sitting here for about 15 months or more now and saying, we'll get through this. Here are some ways to go through this. And I many times I think, let's say this all is placebo. Um, Talking about these things, vitamin D is not the right thing, and ivermectin is not the right thing, and the vaccines are not the right thing. Everything is a placebo, let's say. Even then, just sitting down together, discussing these things and reducing our fear, when we know things, our fear reduces. Just that has, I think, a very important effect on us. And that is, as that video was talking about, if you reduce fear by humor and by logic, then people come out of that state of mind more easily. So I think um, I'm happy that we've been unknowingly doing that together. Teresa Huber, thank you very much for your super chat. Where is France today? Fluffy Bean says, with the increased cases and lack of vaccine for kids under 12, do you think it would be reasonable for a 10-year-old to take a prophylactic dose of ivermectin weekly or every 2 weeks? So, Fluffy, I cannot give an advice to a child directly, so it's not a specific advice. However, ivermectin is actually used more for children than adults. Ivermectin is used for worms or deworming in children. So it is actually used more in children. So majority of the doses are given in children. The only thing that is not known is a frequency of weekly or bi-weekly, because the original dosing has been 3 months or 6 months or once in a year. So I think we have now sufficient data to show that it works fine. It doesn't cause too many of the side effects. So, and the 10-year-old does not have um, the issues a lesser than 15 kilogram baby or lesser than smaller than 2 years of age would have. That is, their blood brain barrier of a 10-year-old is fully developed, a healthy 10 years old. So ivermectin was actually made for children. I mean, we adults take it too. This Matt, you look upset. So Geert, Malone, Yarden, Mikovits don't know what they're talking about, but every doctor sucking on virgin teeth does. You look unhappy. Actually, you know what? Medicine cannot be and should not be looked at groups. We shouldn't say that there are people who are in the Fauci group. I actually do not like Fauci. Or people who are in, let's say, Malone's or Geertz group. Medicine should be based on the science. Even that we know is not perfect at this time. But still, that is a better camp to look at the science. And because of that, if you have been a cool bean for some time, you will actually know that we have been discussing studies for 15 months. And one good outcome of that is it's not just Mubin to bring the translation of the studies to us. We have become used to learning, reading, understanding studies. Any of us can. That means you can do your own knowledge check. You can do your own researches as well. So, having said that, I'll give you an example of how these folks are making mistakes. This idea that innate arm, when you give a vaccine, somehow the adaptive arm becomes trained in a way that when the actual infection occurs, adaptive arm would try to respond and fail while it had already depleted. I'm using these words very carefully because these are the ones that I took from these papers. While the innate arm is already depleted, and so innate arm, which is supposed to now work, is not working, and adaptive arm is already not working. This whole idea, it's not Fauci who would come in and say this is wrong. This whole idea is incorrect. There is no, or let me say it this way, if for some reason somebody's innate arm is not working, they have a severe immunocompromised state for any pathogen, not just this pathogen. They will not survive their own normal flora and fall victim to it very soon and start dying. Because innate arm is not specific, it's a non-specific arm. So if you destroy the innate arm, you're done. The person now has to live in a bubble. So this is one mechanism by one of them, and it's incorrect. Now let me explain the other mechanism by one more of them. This other person says that the ADE is happening. A few days ago, I saw a tweet where they said that, well, I saw this infection in some of the folks. There are early signs of ADE. My God, he's a meter. Meter, the meter that measures something, not meter other way. He's a meter of measuring ADE. He can just look at the cases and say, these are the early signs of ADE. I haven't seen a human with this capability, and sure, he may have that capability. He has some extra vision, but ADE has never been observed with SARS-CoV-2. Number one. Number two, they tried to produce it with SARS-CoV-2, they failed. Number three, SARS-CoV-2 doesn't have any enzyme that will become primed with the acidic environment to allow the SARS-CoV-2 to become active in a phagocyte. There is just no such enzymes. So if you eat up the SARS-CoV-2 and put it in a phagocyte in a normal healthy person, and phagocyte is burning it, SARS-CoV-2 cannot come out. It cannot do what Epstein-Barr virus can do, or what, not Epstein, sorry, anthrax can do, and many other pathogens do it. SARS-CoV-2 just cannot do that. This is another person whose concept is wrong. Then another person who you named, their idea that somehow the DNA is getting altered is also incorrect. Actually, it is a waste of time to spend so much time on these incorrect mechanisms. And this is not that it is a Fauci camp if somebody points out that these are incorrect mechanisms. Yeah, anthrax is a bacteria. So Secret Owl is saying, well, anthrax is a bacteria. Correct. And still, at the end of the day, when it is phagocytosed and it is acidified in the phagocytic vacuole, its enzyme become active. That is a mutation it has done. It has acquired. Its enzyme become active with the acidic environment. Other pathogens get burnt. Anthrax actually becomes active. Now, what we are saying is the folks who are seeing early signs of ADE, they are saying that in our phagocytes, so I should clarify a little more. ADE is not just the phagocytes, there are multiple mechanisms. So here is a cell. One possibility is that antibody and the pathogen are both brought into this vacuole, and over here, when you acidify this thing to burn this pathogen in here, and it uses that acid to come out, or it activates the enzyme. So SARS-CoV-2 doesn't do this. Second mechanism, that instead of the antibody, it is a complement that is attached to the SARS-CoV-2, and then that complement allows the virus to get into the cell, just like the antibody. Again, the virus ends up in the phagocyte, and then it liberates from it escapes from the phagocyte. That again, SARS-CoV-2 has no such mechanism. Third possibility, they say that when a pathogen complexed antibody lands on a macrophage, normally antibodies that do not have a pathogen attached to them or antigen attached to them, they don't sit on the macrophages. They know I'm an empty vessel. But when that gets primed, then it has conformational changes, and it can then become attached to the phagocyte. And then the other mechanism is that once it becomes attached, it is possible that it can start a second messenger mechanism and change the cell's behavior. It's a theoretical mechanism. It has been seen with some viruses like dengue and others in lab environments. They have tried to observe this and create this with SARS-CoV-2, and they were not able to. That's a third mechanism. A fourth mechanism is possibility of complement activation with antibody, and both of them causing this kind of a escape. Again, at the end of the day, there is no such mechanism inside the cell to liberate the pathogen. And then there is a fifth mechanism as well. Point is, if you think about it, if you have the wisdom to question, then I'm sure that you will have the wisdom to go and read and study and up your game. So if you think about this, the folks who are putting those incorrect messages out, and then with every time somebody gets infected, they say, see, I told you they're going to get infected. That is just, I cannot fix it. This is how it is. But at the same time, at least over here, what we can do is we can say, what is it that is happening? What may not be happening? And can we try to be more logical and less fearful and understand what's going on? Okay, so Frisco coupons. Seen you after. I always crack up when I read this because it looks like a commercial as well. Frisco coupons. Coupon difference is preference of 2 doses Pfizer versus 3 doses AstraZeneca at interval of your choosing. So I would stay away from adenovirus if I'm a woman under 50. I'm not a woman under 50, I'm a man above 50, so I am okay with this. But I still, if I have a choice, I'll take a messenger RNA vaccine over an adenovirus based vaccine. And I actually don't feel that there is a third dose needed. So 3 doses of AstraZeneca seem a lot. Why? Why three? Nick says Yali, best up your game. Up your game. We all have to up our game. Um, so Elizabeth, this becomes difficult for me to give a specific advice. Please, would you recommend a 45-year-old thin woman with 10-year history of deep vein thrombosis and vein problems to the point of having difficulty walking plus EBV, get Pfizer or stick with Ivermectin? Um, Messenger RNA vaccines are better than adenovirus based vaccines. So they at least do not have the same risk. Although there was remember I discussed it, there was an Oxford study that said that the risk of clotting with messenger versus adeno is the same. I don't think that was exactly a very good study, but there is a study. Ideally, messenger RNA based vaccines are less um, prone or causative of clotting, especially at this age. So if I was the one at this age, I would take a vaccine. I took my vaccine. If I'm given the vaccine again, although I don't believe in booster, but if I didn't have a vaccine and I'm asked for a vaccine, I'll do it again. If I had an infection, I would go get my T detect and my antibody levels before I think of vaccine. And I was taking ivermectin as well, and I still take ivermectin when I get scared from some exposure, meaning I feel they both need to be combined. Wang says, do you think there is an autoimmune component in long COVID? Do you think autoantibodies were created for both pre and post spike proteins? So, so far the long COVID, how many things have we seen? We have seen one, the monocyte. Monocyte containing spike protein and then the immune system responding to it is not autoimmunity. It's not really attacking our own immune system. It's just continuous activation. Second is, let's say, um, D-shaped, D-shaped uh, blood cells. We did that study as well. So this one is also not autoimmune. It is that the blood cells became D-shaped during the inflammatory process, and then they would get recycled, and then person over time will become okay. Then mast cell activation syndrome. Mast cell activation syndrome, you can put that in autoimmunity, but really mast cells are not really trying to attack us. They are just being helpful. I think that is not something. Autoimmunity is where our immune system actively starts attacking part of our body, thinking that this part is offensive and it is foreign. So MCAS, I think, is not autoimmune. Then macrophage activation syndrome is also not autoimmune, but that can also give rise to it. Then um, could this be that there is some molecular mimicry going on and our immune system has learned to start attacking our blood vessels, for example? Maybe. If that is proven, then that will be autoimmune. Then what else? We have seen that it is possible that the Treg cells, the regulatory T cells, do not function correctly and do not turn off the immune system's behavior correctly. And that might cause long COVID as well. And there may be more. So these are the ones that I have read or thought about so far. Majority of them I've read. This is the only one that is my conjecture. Now, are there more possible? And as more studies will come in, there may be an autoimmune component found at some point, but not yet. Doug says, should an elderly 80 plus get a third dose of vaccine? Doug, that is a very good question. So imagine if I'm thinking about my parents. My parents have passed away, but let's say my parents. At 80 years of age, I know that the immune system has declined. And so the response with one or two doses may not be sufficient. For them, it may be one dose equal even when given two doses. And so it will depend how healthy they are, number one. And number two, their health, how is it handling other pathogens or how are they handling flu? If there is a feeling that their immune responses are not as strong, then a third vaccine would actually not hurt them, because just like they're not responding very strongly to one or two, the third one they would not respond strongly to. So the side effects would not be too many. And that would really act to give some more kick to the immune system. But if they are healthy, their immune system has been working correctly, they do not have any uncontrolled diabetes, they do not have any um, other immunosuppressants or other such drugs, then it may be that they do not need the third dose. So it really depends upon the body health status. Rima says, please, Dr. Bean, talk about each vax and the ways to prevent, minimize possible side effects for each and what to look for it. I want to be able to share this video so people understand there's a safer way to get waxed. So Rima, you have my phone number. Can you do me a favor? Just text it to me. I know I'm going to forget. And because of my absence of Mac will become okay soon and I'll buy a new one soon. Uh, but meanwhile, in this Windows, I do not know exactly how well I can take my notes. So my notes are all over the place. Can you please just text me? Thank you. Michelle says, Dr. Bean, do you recommend 0.4 milligram per kilogram ivermectin weekly for anaphylaxis, or is 0.2 milligram adequate? I have not changed it from 0.2 to 0.4. I still continue to ask for 0.2. Laura says, hit the like button, cool beans. Yes. And Laura, thank you very much. I think once you had sent your picture with with Luffy shirt, I remember you. So create synergistic transformation says, can you explain reverse transcription and why the vaccine cannot? The basic idea, um, and Rajesh, thank you very much for the super chat. I hope there's a question. I'll go see that too. The reverse transcription is an idea to take a piece of genetic material, let's say an RNA, and then convert that into a DNA. By converting it to a complementary DNA, or let's say a DNA, and then that DNA can go maybe get integrated into our system and so on. So the presence of reverse transcription enzymes does not mean that it always happens. And this is what is another false theory that has been given by some of the folks to say we have reverse transcriptions. Most of the viruses or bacteria that do reverse transcription, they carry their own reverse transcriptase. But our cells have them as well, because we do these things as well when we need to. So there have been folks who said, you know what, the vaccines will use our reverse transcriber to then reverse transcribe the vaccine RNA into our DNA, and then that DNA becomes integrated into our system. So so far that has not been seen. So far we haven't seen a vaccine's RNA, messenger RNA, get attached to a reverse transcriptor of our cell. These mechanisms, our cells are much more sophisticated than how we treat them. We think that our cells are just some dumb machines whoever comes in can do anything with them. Viruses do it and we die. That is how serious it becomes. So our reverse transcriptase don't do these things. Can they make a vaccine that will use our reverse transcriptase? Yes. That would be a bad thing on the vaccine makers. So then if you go into those theories that, hey, the vaccine makers are part of some big agenda and they're going to kill us all, and because of that, they would do this. I am not in that line of thought, nor do I believe that they are sitting out there trying to poison everyone. So because I don't believe in that, I don't think in these terms. France says, what can be taken after J&J vaccine for side effects of the last month? So this is the same thing with my wife as well. So fortunate that we, at least for her, I had given her anti-clottings, I had given her anti-inflammatory, painkillers, uh, proper supplements, kept her system as balanced as possible. Even then, she has side effects. And so these are the categories of things: good supplements, good nutrition, less stress on the body, and psychologically less stress. And in addition to that, if needed, blood thinners like aspirin like things. Again, all of this with your doctor's advice, because these can become really bad for a person. And then anti-inflammatories. So Rima says, can you share the numbers of vaccine injury in those over 75? The numbers are low and the risk benefit for vaccine in the population is high. I totally agree with you. The the reason that side effects are low in advanced age, although 70 is not a very advanced age, it's a young age. Still, the reason that there is less side effect is because immune system does not respond overwhelmingly. The folks who were in Netherlands who died, they were too ill and they were already in the terminally ill list. Why did they give them a vaccine is a different question. But of course, somebody who is that ill that we are thinking that they may not survive for a couple of weeks and then try to go and give them a vaccine is just not right. But a person who is healthy and is in slightly advanced age, they can get the vaccine and it would have less side effects because generally their body does not respond that overwhelmingly. So you're correct, Rima. So Veronica says, how Delta Plus escapes the PCR test? Is this the part of concern and not for it being more deadly or contagious? So Veronica, good question. And basic answer is very, very simple. The test systems, so let's say we decide, you and I decide to do business together and we're going to make a test. So here is how a test is made. We say, let's say here is a virus, and what we are going to do is we are going to try to identify the virus with some unique pieces. And now we have to figure out parts of this virus that are unique to it. For example, 86% of this virus is common with other human coronaviruses. If we make a test that picks up some part of this virus that is not unique to this, but actually common in other coronaviruses, then our test is going to pick up any swab and say, yeah, positive. And that test will not work. So, first objective is to figure out a unique part of the virus. So, let's say the spike protein is a unique part. The second thing to decide is, do we recognize the whole spike protein? So let's say spike protein is made up of 1200 um, amino acids. It's actually more, but I'm just making up a number here. Let's say 1200 amino acids. Every 7 amino acids can be an epitope or a recognizable part. So 1200 is a very large number of epitopes. How the tests are made is you make an antibody that can fluoresce, that can have a shine on it because you have attached enzymes with it that can shine. when this antibody is attached to some antigen. And now we create the structure, the binding part of this antibody, in a way that that can bind here. So that means if this structure is seen by this antibody, which is in our test, this antibody. And how did we end up finding this antibody? We know the genetic material of the SARS-CoV-2. We went to some engineers, these molecular engineers, and we said, hey, we want you to create us an antibody that can bind to this part of the um, spike protein pattern. So they'll make an antibody for us. Now we have that antibody, and now we say, all right, we have a test. Send us your blood, and we will see if the virus is there or not. So when people send their blood, they may have this spike protein, antigens in the blood or in the tissue or someplace in the throat. And then we put our antibodies on top of that swab. And then if there is the spike proteins RNA or spike protein pattern, our antibody would bind with it. And then it would fluoresce, and we would check that with the fluoroscope, and we say, yes, we have found the pattern. The problem is, this is called a signal. So we'll say, we found a signal. There is a signal. The problem is, FDA says you should at least have 3 signals. Think about it this way. If we want to make signals for all 1200 and their combinations, there will be lots of antibodies to be made. They need to be manufactured, they need to be tested, they need to be quality controlled, and we don't have enough money to make them all. So we try to make one, and FDA comes back and says, no, not one. One is not going to work. You should have at least 3 signals to 3 unique pieces. So that means now we have to find 3 unique things on this virus and then make 3 unique antibodies that can attach to every one unique part of that RNA or that genetic material. This is how the tests are done. Now imagine the virus had a change in the mutation, delta virus or beta or alpha or lambda or blah. Virus has made changes, and now let's say there is a change here on the genetic material. Let's say delta. When that change occurs, this antibody cannot bind here anymore, the test antibody, and it fails. So we say signal failed. If the other 2 antibodies still attach, then our test is still functional. But mostly when one signal fails, our test kit has failed and we have to go and change it. So many of the test kits are still very successful. There are some test kits that failed because they unfortunately decided for a pattern that became part of mutation as well. So now if I go back to your question, how Delta Plus escapes the PCR test, this is how it escapes the PCR test. And the reason is we have only taken 3 signals from it. Now, would it escape our vaccine-generated antibodies? No, they would not just make 3 antibodies. They'll make epitopes of many types. They would make antibodies against many epitopes. Hundreds of antibody types will be created, or binding material. If we had the original infection, then we'll have also hundreds and thousands of antibodies that can bind to various parts of the virus. So that escape, I think the word escape is an interesting word because it already gives you this pre-canned notion that somehow the virus has made other things failed. But this is what it is. And so this has nothing to do with the vaccine-based idea of escape. Matt, the whole story needs to be or it will collapse. So fear is the drug. So see, we have folks here as well. Trillium says very helpful. Thank you. You're very welcome. And do you know that one interesting thing that they used this in Britain? I discussed it before. Do you know how they found their variant? Their variant in Britain. One of their test kit was failing on one signal and it was succeeding on 2. And that test kit was failing on a new variant. And they used that test kit to see the frequency of the variant by having it fail. So that was very smart. Janet says, "How's your wife?" My wife is much better. So she's 90% recovered. But every time I think that she is now out of it, there will be a day that she has joint pains or she's getting shortness of breath or she's sleepy. So it just keeps um, getting in waves. Uh, LL Hannah says, "Is it possible Novavax prevents transmission?" So Novavax will create the same antibody responses as other vaccines and similar antibody responses as the normal infection. So I don't think it would prevent transmission. I have done this discussion: when will a person's vaccine or infection will prevent their transmission? That will be, so imagine, let's say here at point A, the person becomes either infected and recovered or vaccinated and fully protected, whatever that is. What that means is that their immune system at some point had started making antibodies, and now here it is making a lots of antibodies, including IgAs. And then let's say 3 4 months later, this would go down. But for this 3 4 months time, and more in the beginning, there will be a lot of IgA in the mucous membranes. And if that is happening and the person gets infected, they would not even know, because the IgA present in the mucous membrane would just coat the virus and virus load would stay small and they would probably think I had cold. However, once the immune system has gone down, then the symptoms can occur. Ashley says, if getting vaccine after natural immunity, could that cause an issue? Will it give you stronger immunity? So it, once again, it depends upon the person. For example, if a person is old, they may actually have a benefit from vaccine to kind of kick their immune system again or boost it. If a person is immunocompromised, they might have a use of the vaccine. And folks who have immunocompromised or have less active immune system, their side effects are less as well, because the immune system cannot just go mad. There is not much of the immune system. On the other hand, if somebody is healthy and they have a robust response and their response was good, then need for vaccine is less. So, Bobo, this is a question that I still do not have 100% answer for. Post vaccine tinnitus management. I had that discussion a few days ago as well. I actually know a couple of patients who are post vaccine tinnitus and their tinnitus is not going away. Um, it reduces to a point where they become functional again, but it is really difficult. So, the most important thing is to, once again, I see benefit with ivermectin, with fluvoxamine, with steroids, and then there may be more targeted therapies. But I think very early on, as soon as tinnitus starts, anti-inflammatories should be given so that there is not persistent inflammation that might cause nerve damage. John Thor Abidia says, "Great session. Thank you very much." Um, Adim Nepal says, "For how long does the vaccine work? There is a rumor that one has to take another vaccine after 9 to 12 months of taking your first vaccine. Is this true?" So, not known yet. So far, after 2 doses, you don't need another dose. Rima says, "I felt very, very ill some days ago. I started ivermectin and took flow assay, which showed IgG, IgM. Wow, for SARS-CoV-2, I went for PCR and it was negative. can I do another test to see if it was or not? So can you request for T detect? That would also tell you repeat your IgG, and if you can, I know you're a healthcare professional, if you can, your PCR. It depends. Sometimes PCR would have become negative because your IgAs have taken care of the virus and it's gone. And now immune system is just in this state where it has cleared the virus, and it is just now making sure that it continues to make antibodies so that if the virus comes back, it can beat it. So this is just, I sometimes think about it this way: if somebody's house is attacked, and then the people who attacked, they attacked and ran away, then that person might have guard there for weeks and months, even when these folks never come back. It is the same thing, that virus may have gone and the antibodies are there. So T detect will be interesting. Repeating the tests will also be interesting. Brake says silent damage in the vaccinated. Biomarkers pre and post. Are the damages we see part of a spectrum, with much more damage than it is seen? Brake, I don't know. This is a good question. And I think about the same as well. For example, when my wife has these waves of side effects that come and go 2 weeks later again, or 1 week later again, I think about, is there joint surfaces getting damaged with the joint pains. The reason for that usually is that antigen antibody complexes, those antibodies and antigens that we say cause ADE, these complexes can go and settle on the joint surfaces, cause local inflammation, and that causes pain, or they just cause damage in the local tissue. So your question here, that silent damage, is this possible that a vaccine is, or an actual, so one thing is sure, vaccine or actual infection, they both would produce antibodies. The only extra thing a vaccine would do is it has adjuvants that make produce an extra reaction that natural infection will not do. The only thing natural infection would do is that they may kill the person. So they both have their own pros and cons. Vaccine is safer, more controlled than actual infection in case of SARS-CoV-2. Actually, in every case where there is a vaccine. So can there be silent damage? Maybe. The question is, what will that be? For example, if we say this joint pain is an indicator of a damage, then it's not silent. Can there be silent damage of some pieces? Difficult to then predict. For example, one way of silent damage could be from infection or vaccine is, let's say, pancreatic beta cell reduction. And that is possible to happen, but that would cause pancreatitis, which is not silent. I don't think there will be a lot of silent damage. Lydia says, caught Delta and taking the FLCC protocol, now getting tested in Wednesday, but so far having common cold symptoms. Praying that you stay happy and healthy and recover fast. Okay, so this is what we have for today. There are more questions. We'll continue tomorrow. Lab leak discussion questions are there as well. There are many questions. My apologies. Let's continue tomorrow. So do me a favor, please like, subscribe, and share. And if you would like to support this work, if you like this work, there are links in the description that you can use to support it. Thank you very much, and I would see you tomorrow.